Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, guys, we're going to be covering part 3 of diabetes. We're going to be going over the insulin pump. We're going to be going over adverse reactions to insulin therapy, and hopefully we can get into oral hypoglycemic agents. I thought I was going to be able to do this in 3 videos. I don't know what I was thinking because diabetes is so heavy. And again, I don't want to rush through it because you guys are going to get a lot of test questions on diabetes. I want to make sure that you understand this information. So just rock with me. However number of videos it's going to take, that's what it's going to take. If you haven't done so already, guys, please like this video. You know you're going to like it. Subscribe to this channel. Press that red notification button so you know when a new video is released. And don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. So let's get started. So let's take a look at this. The insulin pump. So guys, this insulin pump, it acts just like your body normally would have acted by secreting those small amounts of insulin throughout the day. Okay, let's take a look. It says insulin pump delivers a continuous sub-Q insulin infusion through a small device worn on the belt, in a pocket, or under the clothing. Make this bigger for you. Okay. At mealtime, the user programs the pump to deliver a bolus, okay? So just a pump, a lot at one time, infusion of insulin appropriate to the amount of carb ingested, and additional amount if needed to bring down or correct the high preprandial blood glucose. So just like normally, your body secretes tiny little amounts of insulin all day, but when you eat a meal or snack, it releases a bolus. Well, this pump is going to release a small amount throughout the day, but the person who has that insulin pump, when they're eating a meal or a snack, they're going to program that pump to release a bolus according to the carbs that they're ingesting, okay? Insulin pump users check their blood glucose levels. Look at this, guys, at least 4 times a day. They're doing it a lot because they have to monitor that blood sugar. Monitoring 8 times or more per day is common. A major advantage of the insulin pump is the potential for keeping blood glucose levels in a tighter range. But the person who's having, if you're having an insulin pump, they got to be on their game. So an insulin pump is not for everyone. An insulin pump is for someone who's disciplined and is willing to be disciplined, willing to learn about the carbohydrates and glucose, and willing to check that blood glucose very often to keep that tight range, okay? Potential challenges of insulin therapy include, insulin pump therapy include infection from insertion site. And we know that because remember I talked to you, I think it was in the last video, anything that is introduced to the body, anything that is foreign, there's a high risk for infection. Increased risk for diabetic ketoacidosis if the insulin infusions disrupted, because remember, especially our type 1s, they're what? Insulin dependent. They absolutely have to have insulin. If they don't, that blood sugar is going to drop. Now, let's say something happens and they're not getting that insulin. Let me back up because I said it wrong. If they don't get the insulin, their blood sugar goes up. It doesn't drop. The blood sugar goes up. And remember, what did I tell you about the type 1 diabetics? Are they more likely to have DKA or HHNKS? DKA, diabetic ketoacidosis. Okay, so this is very important. If that machine stops working, that patient's at risk for DKA because it's our type 1s we're going to be having the infusions. We see this more in the type 1s. The increased cost of the pump and the supplies being attached because it's expensive. Problems associated with insulin therapy include hypoglycemia. What kills a patient faster, hypoglycemia or hyperglycemia? Hypo. So that's a big problem we have to be careful with. Hypoglycemia, allergic reactions, lipodystrophy, and Sofonureas effect. We're going to talk about all of those because you will get questions on those different adverse effects, and you have to know what they are, and you have to know what you have to do for them. So the first one I'm going to go over quickly, that's the allergic reaction. Just, sometimes the patient may have some type of inflammatory reaction. often the doctor will order something like an antihistamine for that. Lipodystrophy. Now, lipodystrophy, you guys really have to know, this is when the area of the skin where the patient's getting the insulin, they're getting injection, it starts to become hard because you keep poking that area, right? And so when it becomes hard, why is that a problem? The absorption is decreased. Lipodystrophy, this is atrophy or hypertrophy of the subcutaneous tissue where you're giving yourself that insulin. It can occur if the same injection site is used frequently. That is why we're rotating sites. And remember, guys, we don't rotate sites by going left arm, left stomach. No, we rotate in one area, then we rotate in another area, then we rotate in another area, okay? Hypertrophy, this is thickening of the subcutaneous tissue, eventually regresses if the patient does not use that site for at least 6 months. That's why it's so important to rotate sites. The patient cannot keep injecting themselves in the same place because this can happen. The use of hypertrophied sites may result in erratic insulin absorption. Why? Because that area is now hard. You think the insulin is going to be absorbed the way it used to? No. Okay. So you want to stay away from that area. If it does become hypertrophy, like the book says, you want to wait 6 months until you start rotating sites in that area. Give the body a chance to heal in that area. So let's talk about Somogy and Don phenomenon because, excuse me, I can almost guarantee you if you're taking med-surg right now, you're learning about diabetes, you will have at least one question on the difference between the Somogy and Don phenomenon and what you would have to do as a nursing intervention. So guys, listen carefully. Somogy and Don phenomenon. Hyperglycemia in the morning may be due to Somogy effect. Excuse me. Both the Somogy and the Don phenomenon, we see high blood sugar in the morning. Both of them. Okay, but the timing is what's our key. So let's keep going. So hyperglycemia in the morning can be due to Somogy effect. A high dose of insulin produces a decline in blood glucose levels during the night. So what is this telling us? With Somogy effect, if that patient gets too much insulin at night, what happens? Their blood sugar drops. Okay, great, their blood sugar drops. But remember, your body's meant to survive no matter what. So if your blood sugar drops too low, you have counter-regulatory mechanisms that will, take effect, or they're supposed to take effect. So when your blood sugar drops too low because you took too much insulin at night, what your body's going to try to do, look at this, guys, is release glucagon. Remember glucagon, that's the stored form of glucose in the liver, right? It's going to release glucagon or epinephrine, growth hormone, cortisol, excuse me. Those are released and that stimulates lipolysis, glucogenesis. The whole point is it makes the blood sugar go up. So let's back up because we're talking about Somogy effect. Let's back up. At nighttime, patient gets too much insulin. Too much insulin, too much of that insulin drops that patient's blood sugar. Okay, patient's blood sugar is too low. Now the body's like, whoa, what's going on? Blood sugar is too low. We have to help the body. What are we going to do? We're going to start shooting out some glucagon, some epinephrine, some cortisol, some growth hormone to make the blood sugar go back up. But then the nurse checks the patient's blood sugar in the morning and they're like, wow, this patient's sugar is high. Let me give them more insulin. Where that insulin that we gave them at nighttime is what caused this whole thing because it was too high. Do you see how that's a problem? Let's look. The danger of this effect is that when the blood glucose levels are measured in the morning, hyperglycemia is apparent and the patient or the healthcare provider may increase the insulin dosage. So it makes the problem even worse. So what do we do about this? Take a look. If a patient's experiencing morning hyperglycemia, every morning you're noticing that blood sugar is high, checking the blood glucose levels between 2 a.m. and 4 a.m. I don't know why this is an underline. I had a pen, here it is. For hypoglycemia will help determine if the cause is Somogy effect. If you check that blood sugar between 2 and 4 and you see the blood sugar is low, then you know it's Somogy effect we're dealing with. Because how is it every morning when I check your blood sugar, it's high, and I feel like I need to give you more insulin, but when I checked you between 2 and 4, it was low. That's how we know we're dealing with Somogy. It's low, and the body's shooting out all of this growth hormone, epinephrine, all that good stuff to make the blood sugar go high, to trick me, the nurse, when I come check you and I see that the blood sugar is high. That's how you know you're dealing with Somogy. You're going to check the blood sugar between 2 and 4 a.m. And if between 2 and 4 a.m. the blood sugar is what? Low. Patient has hypoglycemia, you know you're dealing with Somogy effect. Patient may report headaches upon awakening and recall having night sweats or nightmares. Why? Because of that hypoglycemia. Here's our solution. A bedtime snack, a reduction in the dose of insulin, or both can help prevent Somogy effect. Because remember, the whole point of Somogy effect, the whole problem was the patient got too much blood glucose. The patient got too much insulin at night. So if at night we give them a snack so their blood sugar doesn't drop too much, or we decrease the amount of insulin that we give them at night, that would help. So when we take their blood sugar in the morning, we don't say it's too high. Patient doesn't have to have that counter-regulatory effect. Don't say I didn't warn you guys. You're going to see this on the test. Make sure you know it. So let's recap before I move on, because this is very important for you to understand. If a patient gets too much insulin at night, their blood sugar is going to get really low. Counter-regulatory effects are going to happen to bring the blood sugar up. So when the nurse takes the blood sugar in the morning, they're going to see it's high. So some signs and symptoms you're going to watch out for is that patient having signs and symptoms of hypoglycemia in the night, or them complaining about it, such as right here, the headaches, the night sweats. Other signs and symptoms of hypoglycemia, if the patient's cool and clammy. Remember, cool and clammy need some candy? They report that their skin felt cool, they were sweating a lot in the night, but you're checking their blood sugar in the morning and the blood sugar is high. We're going to test them between 2 and 4 a.m. And if that blood sugar is low between 2 and 4 a.m., we know we're dealing with Somogy effect. We're going to give them a snack at nighttime. Doctor may lower their insulin at night, or even both. That is your Somogy effect, okay? Now we're going to talk about Dawn phenomenon. Dawn phenomenon, same thing, patient's blood sugar is high in the morning as well, but when we check their we check their blood sugar between 2 and 4, their blood sugar will be what? High. So let's look at Dawn phenomenon. Dawn phenomenon is characterized by hyperglycemia that's present upon awakening. So in the morning, their blood sugar is high as well. Treatment for Somogy effect is less insulin in the evening. Remember, we talked about Somogy already. The treatment for Dawn phenomenon is an increase in the insulin, or just adjusting the administration time when we give the insulin. So treatment for Somogy, where between 2 and 4, the blood sugar will be low, but when we check it in the morning, it's high, we're going to do what? Give them a snack at night and give them less insulin at night if the doctor orders. But with Dawn phenomenon, where between 2 and 4 a.m., that blood sugar is going to be what? High. What are we going to do? We're going to increase the insulin dosage, not decrease, increase the dosage, or adjust the time as ordered. You guys have to know the difference between the two and what your nursing interventions will be. If pre-dawn levels are less than 60 and signs and symptoms of hypoglycemia are present, the insulin should be reduced. What are we talking about here? We're talking about that Somogy, remember? If the 2 to 4 a.m. blood glucose is high, the insulin dosage should be increased. That is our Dawn phenomenon. In addition, you're going to counsel the patient on appropriate bedtime snacks so that their blood sugar does not drop too low. All right, let's get into oral hypoglycemic agents. Remember, guys, I told you we always do a step-by-step approach. We're always going to teach that patient diet and exercise. If that is not enough to get their blood sugar regulated, we're going to start with oral hypoglycemics. And if unfortunately that doesn't work, that's when we go to insulin. So let's talk about those oral hypoglycemic agents. The first one we're going to talk about are our biguanides. These are the most widely used oral diabetic agents. Metformin, that is the only biguanide available in the United States. This is the one that most often patients are going to be prescribed. You need to know this, metformin. Metformin is the most effective first-line treatment for type 2 diabetes. That means this is our go-to drug. Once diet and exercise is not working and we have to put that patient on a hypoglycemic, you better expect the nurse practitioner, the doctor, the physician assistant to put that patient on metformin. That is our first-line drug for type 2 diabetic, okay? Forms of metformin include, and you guys can go over that on your own, the primary action of metformin. Look at the action. Look at what it does. It reduces glucose production by the liver. Remember, the liver is what produces that glucose that stores it as glycogenesis, right? It also enhances liver sensitivity at the tissue level and improves glucose transport onto the cells. That tells us something else. It helps the insulin that is already in the body for the tissues to be able to absorb it and use it so that that blood sugar can go down. But there's something very important you guys have to know about metformin. Patients who are undergoing surgery or radiological procedures that involve the use of contrast medium, that's the dye that they're talking about, okay? They're instructed to temporarily discontinue metformin before surgery or the procedure, and they should not resume until 48 hours afterwards once their serum creatinine has been checked. Metformin is hard on the liver. Guess what else is hard on the liver? That contrast dye, that medium. So it's very important that that patient is off that metformin for a few days before the surgery and 48 hours after. And then guess what? We're going to do that BUN creatinine. We're going to do that BUN creatinine. It's hard on the liver. It's hard on the kidney as well. It's hard on both organs. We're going to check that BUN and creatinine. Now, here's something that's important for you guys to know. Another reason why we're checking that creatinine. The kidney is responsible for excreting the toxins, right? So this patient just had contrast dye, had media that is hard on the kidneys. We want to make sure that that kidney is working before we go ahead and give them that metformin again, because that metformin building up in the body can cause lactic acidosis, can cause lots of problems that we do not want to happen. I'm going to cover that in a little bit. So it's very important, after the patients had that contrast dye, we check that BUN, we check that creatinine, especially the creatinine, to make sure the kidneys are working properly, because we cannot afford for metformin to build up in the patient's system. We need, as soon as that patient takes the metformin, the liver breaks it down, the kidney's able to excrete it, because like I said, if that metformin builds up in the patient's body, they're going to be in trouble. This can be deadly. And contrast media is very hard on the kidney. So we want to make sure the kidney didn't get messed up during the surgery or during that contrast media before we start giving that patient metformin again. That is very important, okay? Down here, where they talked about that patient that's on metformin should not resume metformin for 48 hours after surgery, after we check that creatinine, that's on NCLEX. You need to know that. That is very important. And you need to understand the reason for that. And I'm going to go over that in a little bit. But metformin can be very toxic to the liver and can cause lots of problems in the body if it builds up to toxic levels. So we have to make sure that the patient can clear it out the body. And what clears those toxins? The kidneys. So that's why we're doing this. All right. Anyway, let's go to metformin. Do not use in patients with kidney disease. And I just explained to you why. Liver disease, I just explained to you why. Or heart disease, their heart's not going to be able to take, especially if that medication builds up in their body. Lactic acidosis is a rare complication of metformin accumulation. Now, guys, even though it's rare, guess what? It's deadly. We don't want to see it happen. I'm not going to go over all of these, guys. Make sure you read it on your own, because I don't write your nursing exams. You might see one of these on your test. So pause to read. Here's another one. Do not use in people who drink excessive amounts of alcohol. Let me stop right there. I want you to think about it. Alcohol affects what? Among other things, the liver. Metformin affects what? the liver. So does it make sense for us to give metformin to a patient that is already having liver disease? Absolutely not. Didn't they just tell us up here not to give this to anyone who has liver problems? So of course, we're not going to give it to people who have excessive drinking problems, that they may be an alcoholic, because we know their liver is probably going to be shot. Take with food to minimize GI effects. Make sure you guys take a look at this for metformin. You need to know all of it. All right, let's move on to sulfonylureas. Now, where metformin made the tissues more sensitive to insulin so that they can use the insulin and that blood sugar will drop, sulfonylureas work a little bit differently. Let's go into sulfonylureas. Sulfonylureas include glipizide, your glyburide, glimepiride. You guys can look at this. The primary action of the sulfonylureas, look at this, is to increase insulin production by the pancreas. So, and the reason why I'm taking my time on this, guys, you do get questions about the actions of the medications. You have to know the difference. So where the glyburide will kind of make the body more sensitive to that insulin and use it more effectively, the sulfonylureas, they basically go up to the pancreas and they knock on the pancreas, say, hey, pancreas, wake up, make more insulin. That's what the sulfonylureas do. So therefore, hypoglycemia is a major side effect of sulfonylureas, because the sulfonylureas make the pancreas make more insulin. What does insulin do? Decrease the blood sugar. So a major risk is going to be hypoglycemia. What kills people faster? Hypoglycemia or hyperglycemia? Hypoglycemia. Do not give the type 1 diabetics. Type 1 diabetics cannot get sulfonylureas. Think about the action of this medication. The action of this drug class is to walk up to this is the pancreas, and the sulfonylurea says, hey, wake up, I need you to start shooting out more insulin. Well, didn't we learn in part 1 that the type 1 diabetics, that pancreas is dead, is shot, it's not doing anything? So guess what? That sulfonylurea, you give that to a type 1 diabetic, it's going to be knocking on the pancreas door all day. Guess what? The pancreas is not going to do anything. That pancreas is shot. So we do not give this to type 1 diabetics. Professor D, do I have to know this? Absolutely. You're going to see it somewhere again. All right, megalithines. Those are like sulfonylureas, and they give you the medications. Here's what's important to know. Because they're more rapidly absorbed and eliminated than sulfonylureas, they're less likely to cause hypoglycemia. They won't cause the risk for causing hypoglycemia is not as high as the sulfonylureas. When they're taken just before meals, pancreatic insulin production increases during and after the meal, mimicking a normal response to eating, because normal normal patients who do not have diabetes, do not have pancreas issues, what happens? You eat a meal and your pancreas releases a bolus of insulin. Okay, this is what it's saying. So it mimics that same response. You're going to instruct the patients to take megalithines anytime from 30 minutes before each meal right up to the time of the meal. Why is that? Because we know that a bolus of insulin is going to be shot out. These drugs should not be taken if a meal is skipped. Think about it. You take that medication that makes your pancreas release a bolus of insulin, but you don't have anything in your stomach. You haven't eaten anything. What do you think is going to happen? You're going to have a hypoglycemic reaction. Again, what kills people more, hypo or hyper? Hypo. We need to avoid this from happening. All right, am I going to try to pronounce this word? Let's try. Thiazolidine. Okay, you see it. This one right here, this drug class. You see it. Okay, so they're most effective for people who have insulin resistance. So our type 2 diabetics who have insulin, right? But their body's just resistant to using that insulin effectively. Because they do not increase insulin production, this class of drugs do not cause hypoglycemia when used alone. So it makes sense, guys, that we would give this to the patients who already do have that insulin. The body just was not using it effectively. However, these drugs are rarely used today because of their adverse effects, and you guys can go over those adverse effects. I can't tell you last time I've seen a nursing test question on that. That's why I'm not even going over it, but you read that on your own. Important things to keep in mind. Again, guys, our biguanides, only one medication falls under that class. That's our metformin. How does it work? It decreases the rate of hepatic glucose production. It stops the liver from making all that glucose, and it makes the body more sensitive to that insulin's being used. Side effects. Lactic acidosis. You have to know this. Look at this. The metformin must be held 1 to 2 days before using contrast media and 48 hours afterwards. And within that 48 hours afterwards, you better check that kidney function to make sure kidney's working properly before you resume that metformin, because you want to avoid lactic acidosis. Remember, contrast media is very hard on the kidneys, and we want to make sure they didn't hurt the kidneys. Sulfonylureas, how do they work? They stimulate release of insulin from the pancreas. Remember, the sulfonylureas, that's the one that knocks on the pancreas's door and say, wake up, I need you to shoot out more insulin. So you're not going to give that to a type 2 whose pancreas isn't working properly, right? Type 2. You're not going to give that to a type 1 whose insulin is not working properly. Side effects, weight gain, obviously hypoglycemia. For testing purposes, these are the drugs I put a star next to. Those are the ones that I see tend to show up most on nursing exams, but I don't write your tests, so make sure you know all of them. But I just put a star next to them just so you can see those are the ones that tend to show up the most. All right, moving on. And by the way, guys, these are for your non-insulin injectable agents. Okay, glucagon-like peptide-1 receptor agonists. Talk about these. These drugs increase insulin synthesis and they release from the pancreas. They stop glucagon secretion, they slow the gastric emptying, and they reduce the intake by increasing satiety. So these drugs may be used monotherapy or adjunct with other drugs for the type 2 diabetics. These drugs are administered using sub-Q injection, pre-filled pen, and these are 2 examples medications they give you. Here's some important things you guys need to know. For the Byetta, acute pancreatitis, that's inflammation of the pancreas, and kidney problems has been associated with its use. And with the Victoza and the Trulicity, do not use in patients with personal family history of medullary thyroid cancer. And I think you guys remember this from all those Trulicity commercials. That's the first thing they tell you. That's a contraindication, medullary thyroid cancer. Acute pancreatitis, again, has also been associated with this use. And it makes sense because what does this drug affect? The pancreas, which shoots out the insulin, that makes the insulin, right? It makes sense. Let's talk about nutritional therapy. It's recommended that a dietitian with expertise in diabetes management work with the person who has diabetes. Who calls the doctor or the nurse practitioner to ask for a nutritionist consult? The RN. The RN is the one responsible for calling the doctor or the nurse practitioner and asking for consults, not the LP, and the RN has to do that. Guidelines from the ADA indicate that within the context of an overall healthy eating plan, a person with diabetes can eat the same foods as a person who does not have diabetes. But look at the key, the context of what? Look at this, an overall healthy eating plan. This means that the same principles of healthy nutrition that apply to the general population also applies to the person with diabetes. Some additional specific goals: you want to maintain the blood glucose levels as close to normal as possible. Achieve lipid profiles and blood pressure that reduces the risk of cardiovascular disease, because diabetes itself is a risk factor for heart disease. So we want to make sure that we have that cholesterol in check. We want to make sure that we have that blood pressure in check. All right. Down here, type 1 diabetes, which I talked to you guys about extensively in part 1 of my video. Let's see what they have to say. Patients using rapid-acting insulin can adjust the dose before each meal based on the current blood glucose levels and the carb content of the meal. We talked about this already. Type 2. Nutritional therapy in type 2 diabetes emphasizes achieving glucose, that's the blood sugar, lipid, that's the cholesterol, and blood pressure goals. We don't want that diabetic to start having cardiovascular issues. Weight loss is recommended for all individuals with diabetes who are obese or overweight. In part 1, we talked about its effect on the risk factors for being diabetic. A nutritionally adequate meal plan with appropriate serving sizes, a reduction of saturated and trans fats, and low carbs can decrease the calorie consumption. Here's something else you can do: spacing your meals. So let me stop right there. So guys, not only, decrease serving size, because it says right here, let's take a look, decrease serving size. What's a good way to do that? Smaller plates. Start using smaller plates, and that will help to decrease the serving size. A reduction in saturated and trans fats. How do we do that? We teach them to not eat anything that's fried. Instead of frying your food, what? Broil them or cook it in the oven. Stay away from anything that's been dipped in oil, fried, foods with high fat content. Spacing meals is another strategy that spreads nutrient intake throughout the day. Weight loss of 5 to 7% of body weight often improves the blood glucose levels, even if the desirable weight has not yet been achieved. But just the fact that they've lost 5 to 7% of that total body weight makes a huge difference. Regularly exercising, adopting new behaviors and attitudes can facilitate long-term lifestyle changes. Start by walking. Teach them to start by walking. Walk 20, 30 minutes a day. Monitoring of blood glucose levels, hemoglobin A1C, lipids, which is your cholesterol, and blood pressure provides feedback on how well the goals of nutrition therapy are being met. Now, you see, out of all of these, if you had to choose just one that would reflect or give you feedback on how well the goals of nutritional therapy is being met, if you had to choose just one, what would it be, guys? I talked to you about this, I think, in part 2, hemoglobin A1C. That is your key to let you know, okay, the plan we came up with for you, the care plan, the goals, are they being met? Are you doing what you're supposed to be doing, and is it working? Before I go into there, let's take a look at this table. Total carbohydrates. You want the fiber intake to be 25 to 30 grams per day. Non-nutritive sweeteners are safe when consumed with FDA intake levels. So using, I can't think the name of them, but like the fake sugar, but be careful with them because they're high in, some are high in potassium. Protein, high protein diets are not recommended for weight loss. Remember, protein helps build muscle, which you will gain with the weight with the muscles, but those patients who are diabetic, they are not encouraging high protein intake, especially if the patient wants to lose weight. Fat, dietary cholesterol, less than 200 milligrams per day. This has been seen not only on NCLEX for RN, but NCLEX to be a nurse practitioner as well. Make sure you know that. Less than 200 milligrams per day, and more than or equal to 2 servings of fish per week will provide the polyunsaturated fatty acids. Alcohol, look at this. You want to limit to moderate amount of alcohol per day. Look at this, maximum 1 drink per day For women, 2 drinks per day for men. Consume alcohol with food to reduce the risk of nocturnal hypoglycemia. Moderate alcohol consumption has no acute effect on glucose and insulin concentrations, but carbohydrates taken with alcohol, like mixed drink, can raise the blood sugar. Second, guys. Oop. Okay, guys, my time is up because I have to get on the road. So part 4, I'm going to start with the carbohydrates, fat, protein, alcohol. We're going to go over that. We're going to go over patient teaching and more. Oh, we're full of patient teaching. Full of patient teaching. So that's going to be on the next video. I hope you guys found this video to be helpful. Go ahead, let me know what you thought in the comment. I'm so sorry I can't make a longer video, but I have to be on the road. So you guys will be seeing my next video soon. Matter of fact, when I get back, when I get to my destination, when I get to the hotel, I'm going to try to make another video for you today so that you guys at least have a good quarter to half of that patient teaching, because there's a lot in there. And those patient teachings that I'm going to go over, a lot of them are select all that applies on NCLEX. Don't ask me why, I don't know. But when it comes to those patient teaching, and maybe because there's just so many of them, they tend to be select all that applies. So you got to know them like the back of your hand. You don't want to miss one question. So make sure you guys watch out for my next video. Let me know in the comments what you thought about this video. Don't forget to like and subscribe. Audio lessons available for you on my website, nexusnursinginstitute.com. And you guys will see me on the next video.